Today, we will talk about interstitial lung diseases uh, as specific disorder of restrictive lung disease. So, the overall topic is restrictive lung disease. Restrictive lung diseases, they are a group of disorders that characterized by reduction in lung volume. The lung is unable to increase its volume because of many things, either the alteration in the lung parenchyma because of a disease that is affecting the interstitial space or affecting the alveoli, or the problem may be in the pleura, maybe in the chest wall, maybe in the muscles. So it can either be a problem in the parenchyma of the lung, in the pleura, the chest wall, or in the neuromuscular junction. Unlike the obstructive disorders, such as asthma and COPDs, obstructive disorders shows normal or increased total lung capacity. Restrictive disorders shows but restrictive disorders show decreased total lung capacity, as we said in the previous lecture. So measurement of expiratory airflow are reserved in obstructive and restrictive lung disorder. Measurement of expiratory airflows, expiration is preserved. Preserved mean normal. And airway resistance is normal in restrictive lung disease. And the forced expiratory volume 1, forced expiratory volume 1 divided, this ratio divided by the forced vital capacity is increased or normal. Restrictive lung disorders, if caused by parenchymal lung diseases, they are accompanied by reduced gas transfer. So sometimes there will be reduction in gas exchange if the cause is in the interstitial space and the alveoli, which may be marked clinically by desaturation after exercise. So one of the clinical indicators of interstitial lung disorders that is causing restrictive lung disease is desaturation after exercise. Patient, when he is at rest, is normal. When exercise, he develop or she develop hypoxia. So classification of restrictive lung disorder, there are many disorders that causes lung restriction and reduction in lung volumes, and they may be divided into two main groups based on the anatomical structure. Okay, anatomical classification, we classify them according to the anatomy to two main structures. We can remember the causes and the classification by a simple mnemonic, which is paint, رسام, or rasma, paint. So P refers to the pleural, A refers to the alveolar, I refers to the interstitial, N neuromuscular, and T thoracic cage abnormalities. So the cause either be in the pleura, in the alveoli, in the interstitium, in the neuromuscular junction, or in the thoracic cage. So the intrinsic restrictive lung disorder, they cause inflammation or scarring of the lung tissue. The lung tissues get scarred and they are called interstitial lung disease, and sometimes they result in filling of the air spaces with exudate and debris. This is called pneumonitis. So either, if these are the alveoli, multiple alveoli, and they are interstitial disorder, and there are cells here. Okay, sometimes the problem may be here, maybe between cells. So if the problem between cells, this is called interstitial lung disease, a part of the restrictive lung. It's apart from the restrictive lung disease, and this is the intrinsic. So sometimes it may be in the interstitium, so it will be interstitial lung disease. And if it affects the alveoli, and the alveoli become filled with debris and exudates and inflammatory cells, this will be called pneumonitis. Pneumonitis. Okay. So these diseases can be characterized according to the etiological factor. Okay. Anatomically, intrinsic and extrinsic. The intrinsic can be interstitial and can be pneumonitis. According to the etiology, they are idiopathic, fibrotic disease, or connective tissue disease, drug-induced, environmental, and primary disease of the lung. So we have about 5: idiopathic, connective, drug, environmental exposure, and primary disorders of the lung. So 1, idiopathic fibrotic disorder; 2, connective tissue diseases; 3, drug-induced lung diseases; 4, environmental exposure, inorganic and organic dusts; and primary diseases of the lung, like sarcoidosis. So there are 5 classifications of intrinsic lung disorder as per the cause and the etiological factor. The extrinsic, the chest wall, pleura, and the respiratory muscle are the component of the respiratory pump. So they need to function normally for effective ventilation. So anything outside the lung, covering the lung, anything outside the lung covering it, from the pleura, the thoracic cage, outside, and and the muscles, themselves. All these factors, they affect the ventilation, and Any problem in these components will cause extrinsic lung disorder as a part of restrictive lung diseases. So, diseases of this structure result in lung restriction, impaired ventilation, and respiratory failure sometimes. For example, myasthenia gravis, which causes respiratory failure. And these extrinsic disorders, they are considered extrapulmonary, and the intrinsic disorders, they are considered intrapulmonary. So now we're going to talk about the pathophysiology. So the pathophysiology of restrictive lung diseases, you have to imagine that when the air flow inside the alveoli, this is an alveoli. So when the air flow in, the lung, the alveoli distend, all the alveoli is distend, so the lung inflates, the whole lung inflates, and this accompanied by the contraction of respiratory muscle. The respiratory muscle contract, and like the diaphragm and the external intercostal muscles. But during expiration, the deflation occurs in a passive way. They deflate passively. So after the patient inspire and the lung distend, the patient expire. After the expiration, the lung is at which volume? The remaining volume is the functional residual capacity, and the functional residual capacity is a functional volume of the lung that can be, it can be many and be used to maintain oxygenation and to maintain a reserve of oxygen. So the functional residual capacity is the volume of air in the lung when the respiratory muscles are fully relaxed and no air flow is present. So at relaxation state, at rest, the lung volume become at functional residual capacity. The volume of the functional residual capacity is determined by the balance of the inward elastic recoil of the lungs and the outward elastic recoil of the chest wall. So we know that the lung wait. So we know that the lung, when expand, it recoils. Okay, recoils means come back. So the FRC, the functional residual capacity, is determined by the balance of the inward recoil of this lung and the outward recoil of the chest. So the lung have inward recoil. When it expands, it recoil back toward the inside. But the chest wall have an outside recoil, tend to recoil for the outside. So there is a balance between the inward recoil of the lung and the outward recoil of the chest wall, and this balance appear, the net result of this balance appear at rest, because at rest there is no any intentional movement of the thoracic cage by muscle contraction. There is no any active expansion of the lung. So muscles are at resting state, and any volume in the lung is created by the intrinsic recoil forces of the lung and the chest wall. So the distensibility of the respiratory system is called compliance. As we said, the compliance is the change of the volume, the change of pressure, and the change of pressure in response to change of volume. So lung compliance is independent of thoracic cage, which is semi-rigid container. So if the thoracic cage have a problem, the lung compliance will be affected, but lung compliance itself is independent, work in isolation from the thoracic cage. And the compliance of the whole respiratory system is the sum of the compliance of both of the lung and the chest wall. So each structure have independent compliance, but they work together and they are considered together when they are summed as the respiratory system compliance. So diseases of the lung and diseases of the pleura and diseases of the chest wall, all of them they will affect the respiratory system and the ventilation because they affect the respiratory compliance but not the lung compliance. So in cases of intrinsic lung diseases, the physiological effects of diffuse parenchymal disease reduce all lung volumes. In case of intrinsic disorders, intrinsic lung diseases, between the alveoli, so intrinsic lung diseases, they they characterized sometimes by diffuse parenchymal